I'm Melinda Musgrave. I'm a plastic and reconstructive surgeon at the University of Toronto. John?
I'm John Semple. I'm a plastic surgeon at Women's College Hospital here in Toronto and at the University of Toronto as well.
Aaron?
I'm Aaron Grant, one of the plastic surgeons doing breast reconstruction in London, Ontario, Western University.
Tanya?
And I'm Tanya DeLizer. I'm also in London, Ontario at University of Western Ontario.
And we're still waiting for one or two of our members to come online. But while we're waiting for that, I've had an opportunity to look through all the questions that have been sent in prior to the session. And I thank all the participants for sending those in to us. I've curated a few to start the conversation that we're going to have amongst ourselves to try to answer your questions. But I'm going to really encourage you to give us your questions in the Q&A spot. Annie's going to help us follow along with that so we can give a more specific answer to questions that you, the people who are actually listening to us now, have. So the first question, and I'm going to put it out to the panel, is how safe is reconstruction? Is it possible for my breast cancer to come back due to reconstruction? Tanya, do you want to start?
Sure, I can start off. So just in general about the safety of reconstruction in terms of breast cancer recurrence, there's been no evidence to show that reconstruction can contribute to a reoccurrence or to cause a reoccurrence of breast cancer. So from a safety point of view, from a breast cancer reoccurrence risk, it is low. There's risks with any surgery. So I think that's, something that needs to be discussed with the plastic surgeon that you're seeing about your type of reconstruction. But so far, we've not found that reconstruction itself contributes to a breast cancer risk.
John, you have some interesting data you've had about recurrence and breast cancer after reconstruction. Can you share that with us?
Sure. No, I think it's an excellent question, and it's certainly a question that many patients ask. I think that, and it's obviously something that plastic surgeons would be very concerned about if we thought we were putting people at risk of getting a recurrence. And as Dr. DeLizer said, there's absolutely no proof that having any kind of surgery or breast reconstruction will increase your chances of having a recurrence or cancer elsewhere. And in fact, there's several larger studies, including one that we did here in Ontario, that actually showed that. There were thousands of patients in each group, and the group that had breast reconstruction actually did extremely well. So from our point of view, we would be very adverse to offering any type of procedure that would put our patients at risk. And we know for certain that that any kind of breast reconstruction does not do that.
Erin, what do you tell your patients in terms of what you do when you follow them for their reconstruction? What are you looking for when you see them?
For afterwards, post-operatively, then physical exam is what's recommended sort of by myself and our colleagues here in Western. Dr. Tony Zong gave a talk earlier and said that mastectomies and prophylactic mastectomies get rid of 90 to 95% of the breast tissue. So physical exam is still useful for any lumps, or concerning masses. But as Dr. Semple said, and Dr. DeLizer said, we've had studies that do show that recurrences are low and outcomes are still very good. So we do believe that it is safe to do all types of reconstruction.
So I'm going to encourage the audience to please send us your questions through the Q&A. We're going to be happy to take them up. We're just going to pick through a few more of these some pre-submitted questions until we get your questions to answer your specific questions you have for us tonight. So if breast reconstruction is safe, what percentage of women choose reconstruction over not having anything done. What do you think in the province of Ontario, what do you think the reconstruction numbers are like? Aaron, I'll get you to start that one.
I think reconstruction still is sort of not as common. I'm not going to say as it should be, because some women aren't interested in reconstruction, but perhaps the education of patients that it's available and an option to them is not as readily available as we want it to be as of yet, which was why events like today sort of can help get the message out. I think the uptake in the sort of bigger centers like London and Toronto and Hamilton sort of are higher sort of than our more rural communities, and certainly more patients in the larger centers get reconstruction compared to the smaller centers. So I think we do need to do a better job of outreach and making sure that those patients in the smaller communities do have access to immediate as well as delayed reconstruction options.
Tanya, what can we do to promote that?
I think, like Dr. Grant said, events like tonight are really important. So getting the information out there to patients. It's nice to have a large scale event like this one on a national level, but even smaller, more local events, when we're able to do so, I think are really important for patients, and having that network or those support groups locally as well. Speaking to colleagues is something that we can do. So reaching out to our smaller hospitals and the communities around us, and making sure that the breast surgeons who are perhaps meeting those patients first know what options are available and who to refer those patients on to if there's not a plastic surgeon available locally. I think that's really important as well. And trying to ensure that we're promoting plastic surgeons in the smaller communities and supporting them with offering breast reconstruction locally, I think is also very important.
John?
Yeah, thank you. I'm just echoing what Dr. Grant and Dr. Eliza were saying. I think that patients should be reassured that there are well-trained plastic surgeons all over Ontario, even in Sudbury, areas like that, that are really well-trained and experts in breast reconstruction. So there's no need to come to all of the major centers. There are plastic surgeons well distributed throughout Ontario that can easily do breast reconstruction. The other quick fact that I think is important is that it used to be that breast reconstruction had to be multiple procedures and a little bit of a drawn out. So people were adverse to traveling for a whole series of procedures, but there are many options for single stage reconstruction that are excellent and with great outcomes. So I think that there's no need to sort of fear that it's a whole series of operations.
Hi, Muriel, glad you could connect with us. Why don't you introduce yourself, and then I'm going to give you one of the questions that we've all kind of discussed so we can get your viewpoint.
Okay, great. Thanks. My apologies for the group for the challenges electronically. I'm Muriel Brackstone. I'm the medical director of the breast program in London, and I'm a breast surgical oncologist.
So Muriel, the first question that was on the list of questions that we got pre our event tonight was, how safe is breast reconstruction? So from the surgical oncology point of view, what do you tell your patients about the benefits of mastectomy versus lumpectomy and the added surgery with respect to putting breast reconstruction on top of that? What's your bottom line for them?
Yeah, so when we talk about the lumpectomy versus mastectomy, if the patient's a candidate for either, in other words, if they have enough residual normal breast that they'd be able to have a reasonable shape to their breast by lumpectomy alone, then the survival outcomes are the same between the two. If there isn't enough to leave that's reasonable looking, then for those patients, mastectomy is the best option. Whenever we're discussing mastectomy as surgical oncologists, we really are making an effort to include immediate reconstruction as an option, and to go from there to immediate reconstruction and discuss that with the plastic surgeon before we embark. Because really that's something that should be discussed right at the outset, and we can make plans accordingly. In terms of delay in treatment, adjuvant chemotherapy, radiation, or outcomes in survival, there's really no evidence to suggest plays a factor. So I think it's safe from an oncologic perspective to proceed in that way.
Okay, we're starting to get some questions from our audience. Dr. Brown and some other doctors spoke about fat grafting as a very common practice. Are there reasons a patient might not be a candidate for fat grafting, even if they have sufficient fat? And if so, what are those reasons? So, Muriel, how often do you see fat grafting done in the context of breast reconstruction in the patients that you see?
I think pretty often. I think most patients will have a little bit of a contour change. Not everyone's interested in that. Patients are uniformly, I think, really happy with their reconstruction. But if they are interested in some shape filling or contouring changes, then I think probably a lot of them do end up having some fat grafting done.
John, you're a big fan of the fat, as am I. What do you think?
Thank you. I think it's a great technique. I think there sometimes is a misconception that you can build an entire large breast out of from fat grafting. And as much as we would like to think that's possible, we haven't quite figured out how to provide the support and blood supply for fat. But it's certainly used for smaller defects, smaller amounts, as was previously pointed out. So I think that it's a great opportunity for improved contour. And I think there's certainly a lot of research being done on fat and fat survival and using fat from different parts of the body. And the great thing is moving it into an area that's all been irradiated because you're bringing in non-irradiated cells, which tends to rejuvenate that area.
Aaron, is there anyone who isn't a candidate for fat grafting?
For large deformities, large divots or hollows or crevices, if it's a large defect, fat grafting can not be as successful as we want it to be. So I think it's more useful sort of for divots and deformities than actual dents, if I can sort of phrase it like that. So if there's a really large defect, then fat grafting would take a lot of sessions of fat grafting either to provide a result or you'd have to look at some other reconstructive option. So I think it's important for patients to realize we can only inject so much fat and expect it to survive. So we can't inject a softball size of fat and expect that to live. So we have to do small amounts. So not really wouldn't be a candidate for it, but it probably wouldn't provide the result that the patient would hope for.
Tanya, there's a question kind of on a similar line. So a partial mastectomy defect, maybe like Aaron says, it's more like a softball than a ping pong ball. Do you think an implant helps with that type? Is that a reconstruction someone would want to do? Do they have an option to have an implant to fix a lumpectomy defect?
I think that's a very challenging scenario to try and correct a lumpectomy deformity with an implant. Because often, as we're describing it, there's a dent there, and that dent is related to the tissue that's missing, and then the scar tissue that's created from the skin down to the chest wall. So often for those patients, instead of an implant, correcting that with some of their own tissue, if it, like Dr. Grant said, if it's a small, dent or contour irregularity, then fat grafting may be an option. But more often than in those scenarios where it's a dent or a big tether or, as this person described it, a bite from the breast, then it's sometimes a better option to bring in a larger amount of tissue, say a pedicled flap from the back with leaving the muscle alone. Sometimes we can do that where we take skin and fat, but leave the muscle, especially for dents that are on the side of the breast, or sometimes it might mean doing a bigger flap or a DEP flap to fill that defect. But often we can, find some type of soft tissue to fill it in. The difficulty with the implant is that there's still that dent there. You haven't filled the dent. You've actually just put an implant behind the whole breast, which can sometimes make that dent even look more noticeable. So I think there are options when patients have those sort of deformities after a lumpectomy, but implant isn't always the best option or the right option, depending on the deformity.
So, Aaron, do you think there's a percentage or a rule that you could think about or describe to us that would allow you to rationalize to implant versus flap for a partial mastectomy defect?
I certainly think, because for me, implants come in sort of a round sort of shape. We can't use a part of an implant to fill part of a breast. So I think if you're getting above 50% sort of the breast that's gone, I think sometimes implants aren't usually an option because it will cause sort of the deformity to accentuate. So maybe under 25% sort of the size of the breast, if there's a divot there, well, we could talk about fat grafting or other tissue. It really does kind of depend, but I think implants are used more typically for mastectomy, whole mastectomy deformities, rather than contour, improving contour, specifically because they are a round shape, and sometimes if you have a indent or missing partial mastectomy, it won't fill just part of that's needed.
Muriel, would you agree that there's a volume for fat, a maximum volume that you would kind of stick to in most patients?
I'm not really sure. I think that I have seen patients go several times for increasing volume. And so I think that at the end of the day, it ends up being oftentimes the patients are maxed out or tired of having to go multiple times. And I don't know that you get incrementally that much more each time. So it seems to me, sort of as an external person seeing it happening to patients, that the first couple of times is where you get most of the volume fill, and then after that you're accentuating fat necrosis, or you're not getting that much more benefit.
Okay, going along the implant line, John, I'm going to come to you. We have an audience member who wants to know what are the pros and cons of above or under the muscle for implant-based reconstruction, and what would you recommend? How would you make your recommendation?
I think it's a great question, and it's something we end up discussing with almost all of our patients. And I think if it's a prophylactic, bilateral prophylactic type of mastectomy that's being performed, and somebody has often in a younger patient with a reasonable layer of fat in the subcutaneous area, then we will always look at prepectoral as or on top of the muscle as an option. The times when we feel we should go under the muscle is if there is an indication that the patient will require a radiation, just because we feel that, at least at this point, and I think there are some papers out there that suggest that you can radiate on top of implants that are on top of the muscle, but I'm not convinced that's a great option. So if I feel as if the patient is high risk for radiation, then we would go under the muscle. And I think that the advantages are that it's a much more straightforward type of procedure if it's on top of the muscle, and you leave the muscle girdle alone. So in a younger patient that's active, and that it would be an advantage, and also there's less animation in that regard as well.
What about a woman who's looking for a minimal amount of scarring? What's the best reconstruction for that patient? Tanya?
So I think a lot of that really depends on, when the mastectomy and the reconstruction are occurring. If we're talking about scarring on the skin, so the visible scars that we can see, then if you're having immediate reconstruction and you're a candidate for a nipple sparing mastectomy, meaning that you have no droopiness to the breast and you're on the smaller end of the spectrum in terms of size of breast, then we can keep the nipple in the skin, and then we can often hide the scar in the fold of the breast, either with implants or doing using your own tissue or using a minimal scar somewhere else on the breast. But I would say that would be the scenario with the least amount of scarring, and being able to sort of hide it in the fold of the breast. If you're having a delayed reconstruction, so the reconstruction occurring, some time period after the mastectomy is being done, then really what we have to work with is the scars that are already there on the chest. So it's hard to minimize that scar, but we can certainly, with an implant-based reconstruction with tissue expanders and implants, simply just use the scar that's there. But if we're doing a reconstruction using tissue from the abdomen, then we have to bring that skin up to the chest, and that creates more scars on the chest. So I think the scars really do have a lot to do with the timing of the reconstruction, not so much what type of reconstruction you have in terms of implants versus your own tissue, but more the timing and what scars are already present.
Still around implant-based reconstruction, for Muriel, if someone has BRCA1 and they're going to have a mastectomy, what are your thoughts and your experiences with using tissue expanders at that first stage?
Yeah, I think if they are going to need radiation, then I think using a tissue expander probably gives the most amount of flexibility in terms of being able to manage the consequences of that. Otherwise, I think there's no concern, and I think it would really depend on the plastic surgeon's preference in terms of final volume, final size that's desired, whether you would go direct to implant or use an expander.
For all the panelists, I'd like you to tell me 2 or 3 conditions that would give you pause about doing an immediate breast reconstruction, particularly in the context of using autogenous tissue. Are there patients that have certain medical conditions that you think might preclude a DIEP or a tram flap? So let's start with John.
Gosh, well, I think certainly obesity would be one. Somebody that had a very large BMI, that would be a concern for both autogenous and implant-based reconstruction. And any comorbid, any other sort of chronic conditions that would compromise bleeding or predispose to bleeding or affect the blood supply. Obviously, things like additional surgeries in different areas like the abdomen, that could also play a role. Diabetes, smoking, all the big ones I think would be big factors in all this.
Aaron, you want to weigh in on that?
Yeah, I mean, I agree. I think one of the questions in the panel was about diabetes. I think certainly you can still have a abdominal reconstruction or DIEP reconstruction if you have diabetes, but kind of depends on how your sugars are controlled. While your sugars are controlled, and certainly diabetics are more prone to infection, so we might have higher risks of wound infections in those patients. Smokers, really, again, smoking does affect wound healing, and if you picture you're taking a big piece from your abdomen or your tummy, and then you have to squeeze the rest together. So anything that's under tension, you want to heal as best as possible. So smokers have a high risk of having abdominal healing problems. So those 2 patients, and like Dr. Semple said, I think obesity, even though it sounds like, well, the more tummy fat I have, the better it is to build a breast. That is true to a point, and then your risks of having healing problems again down on your tummy go increase exponentially. So that's why some of us, even though you do have some tummy tissue available to rebuild, some of us will discourage you from using that type of reconstruction, and maybe perhaps if you can, if there's time to do it, have weight loss beforehand.
Tanya, anything you would add, conditions you would add or think about that would preclude you from doing an autogenous based reconstruction?
Yeah, so I always say to my patients is they have to be healthy enough to have the general anesthetic. So like Dr. Semple mentioned, if they have any major medical conditions that might, increase even the risk from anesthesia. So heart disease, lung disease, a bleeding disorder, or a disorder that causes increased blood clots would be a concern. I think the nice thing about using your own tissue and doing the DEP flap is we know that it's safe for patients to have radiation to the flap or to have chemotherapy afterwards. And we know that there's not a great risk to the flap survival. So I don't think those treatments would necessarily give me pause to offering a DEP flap reconstruction. It would be more the health of the patient and those things that were mentioned already.
And here's a question I think that you can help us with. Someone who had a diagnosis of ovarian cancer and then found out that they had a BRCA gene and they want to have a mastectomy. Is there a time limit you would wait after that diagnosis of ovarian cancer before you'd want to do the mastectomies?
Yeah, that's a great question. We were just talking about that. I think that there isn't any real guideline, but I tell patients that you wouldn't want to embark on anything like that for at least 2 years because you want to heal from your abdominal surgery. And if you're at high risk of recurrence from your ovarian cancer, what I tell people is we don't even recommend screening with MR maybe for the first few years because you're going to be lying prone. And if you need more operations, then you're going to be hindering what is actually going to be really important treatment. And once we're sort of out of the woods from that part, then then we're able to shift and start to think about the next part. So really trying to compartmentalize one thing at a time so that we don't really interfere with next steps with regards to managing recurrence from ovarian cancer.
I think we have a question that we all can kind of shed some light on is how has the pandemic affected breast reconstruction surgeries in Ontario and in Canada? And what are your thoughts about these types of surgeries being canceled due to its association with cancer care rather than a necessary procedure? So I think everybody's felt the sting of that. John, do you want to start with that one for us?
Sure, and I think it's an excellent question, and it's definitely something that we've all felt for our patients, where there's been a realignment of healthcare resources, and this has come from the top down. But I think there's been a lot of concern across Canada. In fact, there's been a consensus paper produced by the plastic surgeons speaking on behalf and advocating for breast cancer patients requiring or wanting immediate reconstruction, which has been prevented in certain provinces to a large degree during the first and second stage or waves of the pandemic. I think, and certainly that's the case, I would think, now in Alberta as well, currently. I think that, so our feeling is that immediate reconstruction should be part of the mastectomy procedure as well. So they should be really part of that same procedure. And I think certainly the first stages of it are important. And I think from our point of view, we feel that the patient should have access to this going forward, taking into consideration that there are some very difficult decisions being made by the healthcare resource allocation groups that they have a tough job, obviously, during the busiest times. And when the ICUs are busy, they have to redeploy a lot of the nursing that's being used in different hospitals. But currently, many of the hospitals are almost back to normal in terms of that regard.
Tanya?
Yeah, I think Dr. Semple did a good job of summarizing it. I think, we all perform breast reconstruction and think it's a very important part of the sort of cancer treatment journey and advocate for our patients. And the pandemic certainly has caused some delays for sure. And it's been variable throughout the last 18, 20 months, whatever we're in, times. And I think a lot is location dependent and sort of temporal, depending on when the waves have been in the different provinces, but certainly in Ontario, I think things were affected all across the board in all sites. Most sites, I think, are back up to almost normal, but now we do have that backlog and that delay. Certainly, the immediate reconstruction is very important, and we advocate to prioritize for that. And I think, speaking from personal experience in London, I think we did a fairly decent job of making those patients a priority and making our voices heard for our patients. But we've had delays for sure for reconstruction, and we're hoping that moving forward we can catch up on that and make some headway there.
Aaron, did you guys shift and do anything differently for those patients? Like, did you use a lot more tissue expanders, or what was your approach?
We had sort of a few periods of shutdown where unfortunately very little was being done, but our group here was very vocal in terms of trying to continue some of our reconstructive cases, especially if they were linked to an immediate reconstruction. And as we argued that the patient does have cancer, reconstruction is part of their journey, and we didn't want to extend care. So I think as a group, we advocated for that, and we were perhaps a little bit luckier than other areas where we were able to continue some of those immediate reconstructions. We had a few where we temporized, like you said, with shorter operations and placed tissue expanders to hold things. Unfortunately, lots of our delayed reconstructions or other second procedures to exchange a tissue expander for implants or fat grafting or things are the patients who have been delayed. And certainly, while we are ramping up back to speed, we still have a lot of catching up to do.
Muriel, we've seen a lot of our colleagues get extra time, the magical 113% at my hospital. Has anyone offered you guys time to catch up on your breast reconstructions?
The short answer to that is no. And I think in part, we were hindered by trying so hard to manage our current immediate reconstruction patients that we didn't make people wait so long. And sometimes the government only responds to a really long wait list and not so much seeing the urgency per patient. So we need to continue to advocate for that, unfortunately.
Along the same lines, advocating and getting the word out and letting people know, we have a question about mammotech from a mid-sized community hospital. When a patient asks about resources, where do we refer them? And do all the major hospitals in Toronto offer this access? So I think John spoke a little bit about this earlier, that there's plastic and reconstructive surgeons in all parts of Ontario, small hospitals, big hospitals. Anybody think of 2 or 3 resources that they think everybody could use to help the patients in their catchment? John, do you want to start with that one?
Sure. I think the Canadian Society of Plastic Surgeons website has the ability to show where the distribution of plastic surgeons throughout Canada who would be available. And I think that would be certainly one. And I believe the OMA may, or they might be able to do that. But I think also the Canadian Cancer Society, I suspect, would also provide that type of information in terms of reconstruction. Also, the oncological surgeons that are doing the initial cancer treatment should also be able to. I think nowadays it's a pretty common thing to be able to direct the patient to a reconstructive surgeon for options.
Any other resources, Tanya?
Not that I can think of off the top of my head. Like, I would think the Canadian Society of Plastic Surgeons would be sort of the first place to go to in terms of seeing where there are plastic surgeons available. Yeah.
I also tell people there's a lot of great support groups, Willow, those sorts of things. There's also small groups often within the hospitals where plastic surgeons have curated some of their patients who are willing to talk to other patients about it. So I think there's lots of outreach that can be done in all of those manners to try to get more word out that there are a lot of possibilities. There's another question here that I've seen a couple of times. I'm having a double mastectomy in the new year and I'm having radiation. I'd like to have a reconstruction done as soon as possible, but want to avoid complications to the new breast by the radiation. What would you recommend? And would it be better to wait until after radiation? So, Aaron, as a DFB type B person, autogenous tissue, what would you say to this patient?
I like that. I'm a DFB type of person. Yeah. I would say that, yes, it depends on what type of reconstruction that you want. Certainly, our own tissue tolerates radiation better than implants do. So if you're a patient and you have, I like to say, if you have a breast on your tummy and you know you need radiation, then I think that's a very reasonable sort of option sort of to do upfront, especially if we can save your skin or even your nipple for the reconstruction, then probably the outcomes are better. You will get some change in the tummy tissue that's been radiated, but not a significant amount. But I think if you were using implants don't tolerate radiation as much. And so we really try a number of things to try and decrease the risks of complications, but they still are fairly high. So upwards of 30% of having the implant getting really tight or the skin envelope getting really tight and us having to try and salvage that. There are a number of other complications that can go along with radiation. So sometimes we try and put a tissue expander in if you don't have a tummy tissue or there's no other option. Then we do try to preserve your breast skin and maybe your nipple, and then sometimes leave a tissue expander to stretch it out, or we do a lot of fat grafting after. So there are options. I would say it's not contraindicated from our standpoint, but there are potential issues. So we'd have to sort of assess you individually and give you those numbers and decide between your surgeon and yourself what that risk profile looks like and what's best for you. But certainly tummy tissue tolerates radiation better.
Is there a general consensus in the room that autogenous is better when radiation is involved?
I would say yes.
Yeah.
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 Yeah. I think that's a universally held principle for most plastic surgeons. We're down to our last 5 minutes, and there's one other question that's been hopping up on the feed and also on the pre-questions. There's a lot of talk about sensation, and not only just nipple sensation, but skin flap sensation. So what do you tell your patients about skin flap sensation and or nipple sensation if they're going to have prophylactic mastectomies or mastectomies for cancer? Muriel, you want to start with that one?
So I tell them uniformly that their breast skin will be numb and that their nipple will look normal if we're saving it, but it will feel numb. What does it tell?
Dania?
Yeah, I tell the patients the same thing. I also, some patients have some sensation afterwards, but I wouldn't want to lead people down the wrong expectation. And I think, expecting things to be numb and to not have sensation is more the norm for sure.
Aaron, what about the whole idea of this nerve sparing allografting nipples? Where are we at with that? Where are we going to go with that?
I think I think certainly if we could sort of identify the nerves that supply the nipples and keep it, then obviously sort of that would be best. I think there are definite challenges because it's not just one single nerve that supplies the whole breast. There's sensation to the nipple, but then there's sensation to the areola and there's sensation to the upper part and lower part. So it's multiple different nerves sort of that are involved. So I think it is a challenge from that standpoint. It's not to identify nerves that are within sort of an area that breast tissue and breast cancer can be intertwined. So I think we are doing some research, but I think, to be honest, I think we're probably a little ways away from being able to do that.
So in our last few minutes, I'd like each of the panelists to give their top tip for two things. How do you get a consult for plastic surgery when you're planning for a mastectomy? And number two, what's your favorite operation to offer a patient and why? John?
Oh, gosh. Sorry, the first one was like, what's the best tip to get a consult? Was that?
Yeah, what would you tell a patient who said, I'm having a hard time getting a consult, like, what should I do?
I think I would just keep trying. I think that they should go through their family doctor, go through the surgeon or the oncological group. They should be able to find them a consult. The wait times, particularly for immediate, should be fairly direct, I would like to think. So I think that just persistence and it shouldn't be such a difficult thing to do. That would be my feeling. The other thing, my favorite operation to offer somebody would be no operation at all. If we didn't have to do this whole thing, it would be fantastic. If we could think of a cure for cancer, it would be wonderful. And if we didn't have to do this, it would be amazing. I just want to point out Dr. Musgrave has done a great job at moderating this session, but she hasn't really offered her opinion, and she's an excellent plastic surgeon working at Unity Health here in Toronto as well. So
I'll save my 2 cents for the end. Aaron, how does someone get to see you and get DEP'd? Because that's what you're going to love to do, isn't it?
Yes, exactly. Well, I think, yes, family doctors should know which plastic surgeons in your area are doing reconstruction. And then the other thing is, most centers do have a breast center with a lot of breast oncologist surgeons like Dr. Brackstone. And so our center patients typically get referred to the breast oncologist first, and then the breast oncologist will refer them to the plastic surgery group. And so we work closely together. And so I think, yeah, reaching out to your breast centers would be a good idea. And I'm a DEPI person, as you said, so I do like using tummy tissue to rebuild the breast. But also a new favorite of mine is working together with the general surgeons to do oncoplastic lumpectomies, and for the really large lumpectomy deformities, really trying to rework the breast to shape it at the same time while preserving some of the natural breast. And so I think that's an exciting area, and I really enjoy being part of it with Dr. DeLizer and Dr. Brackstone, because we all work together for those types of things.
Tanya, how does someone get to see you or your colleagues, and your top tip for them for reconstruction?
I think the best thing is for patients to be their own advocate. And if they want to talk to somebody about breast reconstruction, is to ask for that consult. And like we said, if you have a diagnosis of breast cancer, you're going to see an oncologist, a surgical oncologist. And if you're interested in breast reconstruction, ask for that consult, because certainly having that information available is helpful. And all you have to do is ask, and they should be able to connect you. My favorite operation to offer is the same as Dr. Grant's, doing the oncoplastic lumpectomies, where we sort of reform or rebuild the breast at the lumpectomy and do a breast lift or breast reduction on the other side. I think it's really great for patients. It's a nice way to preserve breast tissue, give them a nice result. And I do like a good DEP, especially both sides DEP, because that usually means I get to operate with Dr. Grant, which is always a fun day. So
Definitely a joy. I know that experience myself. Muriel, I know you're a big proponent of oncoplastic, and I certainly would love to have the opportunity to do more of that. Tell me where you think that's going, because I think that's something that we really want to start championing more in Ontario. Don't you agree?
Yeah, I think that's a great option for patients that are a bit larger, that are a bit droopier, that have extra. You can take, half of the breast, remold what's left, do a reduction lift, and with these colleagues, a beautiful balance. And those patients, I think, are some of the happiest patients. Always kind of wanted a breast reduction, but then now they have a reason to, and you can't get rid of the cancer with wide margins. It tolerates radiation very well. That part's a great win. If you can't, and you have to have a mastectomy, I think my favorite is the nipple sparing, because you hide the incision at the inframammary fold, and I think that's a great option. I did want to say for access to reconstruction that I want people to know that that's part of the Canadian, the Cancer Care Ontario or Ontario Health breast pathway, meaning that it's an expectation, a standard in the province, that if you're having mastectomy, you have access to a plastic surgeon to discuss reconstruction options. And so you should feel completely entitled to advocate for that. And sometimes the community surgeon might not know. He says, oh, you know what, it's easier to get later. Say that's okay. I want to hear it up front anyway. And if they don't know who to send it to, then send me to the, the cancer surgeon in the next city, and they'll know who to send me to. And I think that you won't regret at least hearing if that's the right option for you.
And so for me, I love an immediate reconstruction. I think my best results are with immediate reconstruction. I think my best results are with skin sparing, nipple sparing. And there's very few people I won't have a crack at doing that, because I think you can always find an implant or a piece of tissue that will mimic the shape. So I think more women need to ask for immediate reconstruction. I don't think waiting a week or two to see a plastic surgeon and getting a new surgical date impacts your cancer in any way. And so I don't want people to be afraid not to advocate for themselves, to have at least a consult about it. At least you know about it. The saddest thing for me is to have a woman come back and I have limited options for her now because she has had radiotherapy or there's been something else done. And they say to me, I wish I had known. I don't want anyone to ever come back to me and say, I wish I had known. I want everyone to have that opportunity. I want them to have at least a talk with someone. Even if you think it's not something you want to do, it's worthwhile having that session just to see that you know what things are about and advocate for yourself for all of these things. I know there's lots of questions on the chat that we didn't get to tonight. We're going to pass these on to the Canadian Cancer Foundation to help answer them. I asked if we could probably, just take a few of the questions up and send you private answers, but apparently we're not going to have that opportunity. So on behalf of all of us, I'd like to thank you all for your attention. I really want to thank the speakers for their thoughtful answers, and we look forward to seeing you in the future in our offices.